So these are my disclosures. College of American Pathologists, the International Association of Study of Lung Cancer, and the American Molecular Pathology Group have come out with some new guidelines. They're not quite in press yet, but one of them is non-small cell lung cancer is no longer acceptable as a pathologic diagnosis or as an operational category for clinical management. You've probably heard that before, but this is the pathologist saying that. Why do you need to know what the cell type is? Well, here are 3 reasons off the top of my head. Adenocarcinoma are not otherwise specified, have to be tested for EGFR or ALK mutations. Patients with adenocarcinoma are not otherwise specified cancers. Non-small cell lung cancer, not otherwise specified, respond best to pemetrexed than squamous cancers do, and potentially life-threatening hemorrhage can occur with squamous carcinoma if you treat it with bevacizumab. So the landscape has changed. These rules were not there 5-7 years ago, but it's changed dramatically now. Now, you all know about the Philadelphia chromosome, which was identified in 1960, and then it was shown to be a translocation, but it wasn't until about 10 years later that it was found that that translocation results in this BCR-ABL fusion gene, which drives the cancer. And so that it can be blocked with this inhibitor, the imatinib, and this is standard therapy. So here are 5 cases where standard therapy is with a targeted agent, and it's the standard of care. Herceptin, trastuzumab for breast cancer, well known. We're going to talk a little bit more about erlotinib for EGFR mutations. Cetuximab, the drug that Martha Stewart went to prison for inside trading over, shows it's not effective if you have a KRAS mutation and you have colon cancer. About 50% of colon cancers have the KRAS mutation. Here are a number of drugs that are all FDA approved in 2011, and one of the big news this year is the melanoma drug that targets the V600E mutation. So how do you know what these mutations are? You got to get tissue. And again, part of what we're going to talk about a little bit later on. But here are like over 11 new drugs, FDA approved targeted therapy. The landscape has changed, it's changing rapidly, and it's going to change even more rapidly as I'll show you. Now, for those of you who don't do this every day and are confused about all of these names, there's this website, genenames.org. If you want to know what MAPK stands for, MAP kinase, you can plug it in and it'll tell you what it is there. So just in case you're interested. We're going to talk about driver mutations. Now, a driver mutation confers a growth advantage. So that's the BCR-ABL driver mutation that causes chronic myelogenous leukemia. There are also passenger mutations that are biologically neutral, but do not give you a growth advantage. So different types of mutation, not all mutations are drivers. Most of the driver mutations that we know about so far have occurred in adenocarcinoma, but that too is going to change. So here is the HER family, HER 1, 2, 3, 4. HER1 is also known as EGFR, epidermal growth factor receptor. And it is the mutations in the tyrosine kinase domain, the intracellular domain. So these receptors, and there's thousands of these receptors on all cells, have an external domain and an internal domain. And the external domain is driven by certain ligands or drivers. And when that happens, you get a dimerization, and then you get a proliferation, cell proliferation, survival through these different pathways. The PI3 kinase, the AKT pathway, or the RAS-RAF-MEK pathway. So like I said, it's going to get easier now here. Just keep following, and you're going to hear a few more names. But again, were this drug, gefitinib and erlotinib, it's a tyrosine kinase inhibitor, and it blocks intracellularly to prevent this proliferation. And you've already seen a couple of great examples of that from Teresa's talk. of how these folks respond. So 90% of the EGFR mutations in the tyrosine kinase domain are sensitizing mutations, and they're due to exon 19 deletion or exon 21 mutation. These two cause 90% of the EGFR mutations. There are some others, and I'll show you those a little later. And there's also this resistant mutation. If you have the T790M mutation, you are not likely to respond to the tyrosine kinase inhibitors. So this is all important in trying to decide what treatment is. So here's our friend EGFR. It has the external domain, the extracellular domain, and this is the target for cetuximab, a monoclonal antibody to the external receptor, and the blockers of the internal tyrosine kinase domain for these two major deletions, exon 19, exon 21. The internal domain there, a small molecule, this is where erlotinib and gefitinib block. Like I said, it's going to get easier now. So there are a number of receptor tyrosine kinases, the EGFR, HER2 is the important one for breast cancer. The insulin-like growth factor receptor, MET, is one that's coming on in lung cancer. It may be important. I'll show you a couple of drugs that are in phase 3 trials. The VEGF, vascular endothelial growth factor, are receptors on the cell surface that have tyrosine kinase domains. And here's where all the development is going on. You have monoclonal antibodies to the ligands. Hepatocyte growth factor is the ligand for a MET receptor. So you have these drugs that attack the ligand. You have drugs that attack the external receptors. You have drugs, erlotinib, gefitinib, that block the internal tyrosine kinase domain. And then you have drugs along these various pathways. A number of drugs, the sunitinib, is a drug approved for kidney cancer at this point in time, and it blocks the VEGF receptor. It's a tyrosine kinase inhibitor. So again, this is where the field is going, and we have a lot of good examples. So I'm a lung cancer guy, and so let me tell you about the landmark study, the IPASS study. Basically, this is what got the tyrosine kinase inhibitors approved as frontline therapy by the FDA. This was stage 3-4 disease, performance score 0 to 2, light or never smokers, adenocarcinoma, and it was done in Asia. So again, you have Asians, you have adenocarcinoma, you have light or never smokers, so you're stacking the deck for a higher likelihood of having the EGFR receptor. This study was published in 2009, which means it started back in 2006 and 2007, and EGFR mutation testing was not standard in all kinds of laboratories, but they collected the material to be able to do mutation. So they ended up, there were 1,200 patients in the study. They got over 400 samples for EGFR testing, about a third. Most of the mutations were identified in 60%. This shows you cannot profile. If you profile, you get the best group, the best of the best, only 60% of them had the mutation. So the usual mutations are the exon 19 and the exon 21 mutation, as you see here. And rarely do you have the T790M, which is a resistant mutation, present only in 4% at baseline. So if you are mutation positive and you treat the patient with frontline gefitinib, an oral agent, without the usual chemotherapy toxicity, you got a 71% response rate. But with standard chemotherapy, Taxol and Carbo, which is standard doublet chemotherapy for frontline stage 4 disease, you still got almost a 50% response rate with that chemo. But if you were mutation negative, to the right there, you can see only 1% of people who were mutation negative responded to gefitinib. They responded better to frontline chemotherapy. And when you look at the progression-free survival, which was the main endpoint of the study, what it says is if you have the mutation, you're better off getting gefitinib. Your hazard ratio here for time to progression was 0.8. So again, you're half as likely to die or have progression, if you were mutation positive and received gefitinib. In the contrast, if you were mutation negative and you got gefitinib frontline, you did worse. So you can't just treat everybody frontline with this drug because you're going to have a detrimental effect in this group. You need to know the mutation status. The point of this study shows just what I said, is that you cannot treat everybody frontline without knowing the mutational status. This is a randomized trial. They got frontline erlotinib, which is the drug Tarceva that we use in the US for our tyrosine kinase inhibitor, or they got doublet chemotherapy. And basically the study was stopped early because the erlotinib arm was doing worse. And again, they didn't do typing, so this was all comers without typing. So you have to type the folks and know if they're mutation positive. So here was a paper out of Spain where they took over 2,000 cases of non-squamous, non-small cell lung cancer. They did mutations. They identified mutations in 16% of these individuals. And again, it was the same exon 19 and 21 sensitizing mutation. And what they saw was if you take all females, 30% of them have the mutation. But you can't totally exclude men because the males had an 8% mutation rate. Never smokers had a 38% mutation rate, but former smokers and current smokers had some mutations also. Adenocarcinoma had a 17% mutation rate. Adenocarcinoma in situ, the artist previously known as BAC, had a 23% response or mutation rate. So again, you cannot profile. Profiling doesn't work, you have to do the test. So here are basically these two papers published 2009, New England Journal, back-to-back papers, and both showed the same thing. If you have a mutation in the Spanish study, your major response rate of complete response and partial response, 70%. Same in the IPASS study. If you have the mutation and you get frontline treatment with the tyrosine kinase inhibitor. Here are 5 papers in the literature, all looking at, these are all looking at gefitinib or Iressa, and as I said, in the US, the one that we are using is Tarceva, but again, same types of activity, progression-free survival 10 months, and median survival time for stage 4 disease, 2 years. Now recall that stage 4 disease has a median survival without treatment 4 to 6 months. With doublet chemotherapy, it's 9 months. With doublet chemotherapy plus Avastin, it's 12 months. Now we're looking at frontline therapy with 24 months median survival with this. So this has clearly changed the landscape of how you treat this disease. And here's my anecdotal case of a 82-year-old African-American lady that I saw at National Jewish Health. She came in the wheelchair, short of breath, performance score 2 to 3. She literally was probably within 2 months of death. And we tested the pleural fluid. She had an exon 19 deletion. We put her on erlotinib, and now a little over a year out, you can see the major shrinkage of her upper lobe, resolution of the pleural fluid. We got her Pleurex catheter out of there within about 2 weeks after starting the Tarceva. So the upper pictures here show the fluid and the mass in the right apex, fluid located there. The lower pictures are after she had her response. Did we cure her? No. However, we have bought her a significant amount of time, and all because we did the EGFR mutation testing. No way she could have tolerated a doublet chemotherapy. You know, it would have blown her away. She was so frail, but she could tolerate an oral pill. So recently, this paper has come out in Lancet Oncology, and basically it just says that they used erlotinib, which is Tarceva, in these folks. And if you look down here, they randomized them if they had the mutations to erlotinib or chemo, and the median survival time, the line right above the orange there, 9.7 months versus 5.7. So the point of this, they said, is routine testing of epidermal growth factor mutation is strongly recommended. Let's just skip that one. Who would I do this testing for, EGFR and ALK? Well, I do it on adenocarcinomas. Generally, we're talking about unresectable patients that we do this on. Resectable patients still go to surgery, whether they have the mutation or not. I do it on adenosquamous carcinomas. I would certainly do it on large cell carcinomas. I do it on poorly differentiated, not otherwise specified, although I hope this term is going to go away soon. I would do it in a squamous carcinoma who was a never smoker, because pathologists don't always get it exactly right, but some squames have been reported in the literature, especially in never smokers who've had the mutations, and I certainly would do it in a younger patient. Any patient 50 years of age or younger needs to have this mutation. Now, the American Society of Clinical Oncology came out with this statement saying response rates, if you have the mutation, is going to be in the 60 to 80%, and they strongly recommend testing. So multiple groups now have come out saying that this is the standard of care. So the paradigm has shifted. We do this routinely before treatment. We're going to talk a little bit about biopsies here in a minute, but when people relapse, and they will relapse on this disease, they relapse for a reason. Some of them, they relapse because they developed this T790M mutation. Others have MET amplification. There's actually several interesting papers showing there's a transition from adenocarcinoma cell type after treatment with an EGFR inhibitor to a small cell type. That may only happen 5% of the time, but you won't know any of this stuff unless you biopsy these people when they recur and you do further testing on that. So that gets back to the point of biopsy. One other point I'll mention about KRAS mutations. They've been around a long time. They're the most common mutation in adenocarcinoma, and they predict resistance to the tyrosine kinase inhibitor. These mutations are mutually exclusive. So if you have one mutation, you don't have the other mutation. If I've got a KRAS mutation, I'm not going to have an EGFR or an ALK mutation, and vice versa. So it helps you from that point of view. It doesn't help so much with treatment. Now, the new mutation that's made a lot of noise in the last year or two is this ALK mutation, EML4 ALK. ALK has a number of fusion partners, but EML4 is the most common, and that stands for echinoderm microtubule-associated protein like 4, EML4, and it is fused to the intracellular kinase domain of anaplastic lymphoma kinase, ALK. ALK's been around for a while. It was obviously discovered in lymphoma. This activity can be blocked with a tyrosine kinase inhibitor. Teresa already mentioned that to you. This mutation was discovered in 2007. And in 2011, we now have an FDA-approved drug for this mutation. This is how fast things are changing. I told you the Philadelphia chromosome was discovered in 1960, and it took up until about 10 years ago to figure out what the driver was in that, and we have treatment for that. Now we have another example in lung cancer within 4 years of identifying a new mutation and having a drug for it. So basically, chromosome 2 gets an inversion. It results in this ALK fusion protein, which drives cellular survival and proliferation, sort of the mechanism of these driver mutations. So in this paper from Alice Shaw and groups, they screened 141 non-small cell lung cancers and followed these individuals. They had two of the following. They were either Asian, female, light, or never smokers. Again, they're trying to stack the deck for mutations. What they found was that 19 of 141, 13% had the ALK mutation, and 22% had the EGFR mutation. So you can see that's a third of the individuals here that have one of the two major mutations that will dictate therapy. How do you quantify the ALK mutation? Well, it's a FISH assay, fluorescence in situ hybridization, and you have this so-called break-apart probe, So if you have the mutation, you can see your red and your green probe with a distance in between. That means the mutation. If you don't have the mutation, these two are right on top of each other and it's yellow. So you have to have 15% of your cells. They have to count over 50 cells that have this mutation, and then it's called ALK positive. You cannot prescribe the drug without having a FISH test that's positive. All right, so question, how many of you do diagnostic biopsies? Can I see a show of hands? Quite a few. Okay, so these next 3 slides are for you particularly. And I polled 5 different pathologists around North America and asked them how do their people do it? How do they get good samples to them for them to do molecular testing? So from University of Toronto, Dr. Getty says cytopathologists and cytotechnologists attend all biopsies of EBUS, endobronchial ultrasound, or CT-guided FNAs. They use the rapid on-site evaluation. They ensure malignant material is obtained, and when you don't get enough tissue, they say, give me more, come on, biopsy again. That's their job, to make sure you have sufficient tissue, pathologists, so that they can do the job. Now, obviously, you're calling the shots because you're the one putting the needle into the patient's chest most of the time. Dr. Aubrey from Mayo Clinic said all testing is done in paraffin. The main thing is for the cytologic specimens, including pleural fluids, is get them embedded in paraffin. EBUS usually provides only about 1 block, one good sample for paraffin. That was her experience there. And pathologists must due diligence in choosing how to handle the sample. So again, it requires coordination between you, the invasive radiologist, and your pathologist. If either one of you fall down, it isn't going to work. And then the oncologist is going to be he's going to be sending the patient back to you for another biopsy because you didn't do the job well enough the first time. Dr. Eisner and Dr. Franklin from the University of Colorado said, wait a minute, send the tissue to the molecular pathology lab. They're both molecular pathologists. Don't send it to the regular lab, send it to the molecular pathologist. They want 2 biopsies with cores. They put each core in a separate block, and they want 1 fine needle aspiration to spin it down. So again, I think you spin it down, you do the cytologic evaluation, make the diagnosis of malignancy off of 1 core, you do your immunohistochemistries, and off the other core, you're doing your molecular testing. So it no longer is acceptable just to get a couple of cancer cells on an aspiration. You've done only half of your job. And that's not only for lung cancer, although that's what I'm talking about today, but I got to emphasize these mutations are important in metastatic melanoma, metastatic breast cancer, metastatic colon cancer. They are driving therapy in all of our cancers, so you have to have good tissue. So the FDA this past year approved crizotinib for the treatment of ALK-positive individuals. Approved the companion diagnostic, this FISH assay, to look for the ALK break-apart probe. This is the new direction that the FDA is going in. They want a marker to help them tell if this targeted agent is going to be beneficial to the patient. That's kind of the way the field is going. And it's based on, FDA approval was based on basically 2 studies that had 50 to 60% response rate with the crizotinib. There's a very low major adverse event rate of about 4% that were grade 3 or grade 4. There is this fatal pneumonitis that they saw in about 1.6%. And again, that's similar to the Tarceva and the Iressa, which have a low rate of major fatal interstitial lung disease. Here's what's called a waterfall plot. Teresa told you about this 30% line, which is the RECIST criteria. If you have a 30% shrinkage of the tumor, it's a response by RECIST. But the waterfall plot is used commonly in oncology, and each one of these is a patient, and it shows how much his or her tumor shrunk. You can see here, these folks are essentially a complete response, 100% shrinkage. So the waterfall plot, this is a wildly positive study, and this is again crizotinib in ALK-positive patients. And these folks have about a median survival somewhere 9 months according to this study. And here is my anecdote. So here is our PET scan, and you can see a lot of disease right in here. Right there's the primary, a fair burden in the liver, and 14 days later, you can see very little activity here. This thing is shrunk way down. The disease in the liver is down. The intra-abdominal lymph nodes. This is what you call a gee whiz type of response. So this is what every oncologist loves to see, and if we get one, we always make slides of it. So paper just came out a couple of months ago. Again, Alice Shaw and the group from Boston looked at ALK-positive patients enrolled in the phase 1 trial, compared those to ALK-positive patients who did not get crizotinib. So what they noticed was that if you got crizotinib and you had the mutation, your 1-year survival and 2-year survival, 74% and 54%. Now remember, these folks without treatment would be dead in 4 to 6 months, median survival, most of them. So if you did not get crizotinib, that's what your median survival was, basically 6 months, as compared to the 54% 2-year survival. So survival in the ALK-positive patients getting crizotinib is very similar to the EGFR mutation-positive patients getting the tyrosine kinase inhibitor, erlotinib or gefitinib. So again, dramatic change in how we approach therapy. So this was, I think, a landmark study, the Lung Cancer Mutation Consortium at these centers around the country. They got 1,000 tumors and they tested them for all of these mutations that you can see here. They were successful in doing mutation testing and FISH analysis in 500 of the cases. And basically what they showed was KRAS mutations #1 at 22, EGFR and ALK, but there are also a number of other mutations here. And this month in the clinical cancer research, they're talking about ROS mutations, which are also sensitive to crizotinib, and they occur in about 1 or 2% of individuals. So again, you don't know if they have these mutations unless you do the biopsy and do the testing. Squamous carcinoma has been ignored up until recently, but 30% of the lung cancers are squamous carcinomas. They're doing this Cancer Genome Atlas evaluation looking at squamous carcinomas, and they're particularly interested in these genes that are listed down here. MET amplification occurs in about 6% of squamous carcinomas, and MET, tyrosine kinase inhibitor of MET is crizotinib. So it also works in ALK and it works in MET inhibitors. So again, the reason you need to know that. There are 2 phase 3 studies coming out. This is a monoclonal antibody to MET, which is a cell surface receptor, and then there's the Japanese study with the tyrosine kinase inhibitor, also in phase 3. So we may have another drug if these studies are positive. And this is my slide to remind you that it's only going to get easier. Okay? Here's the external receptor, and here are the drugs that are being tested that will block MET external receptor. Here are the tyrosine kinase inhibitors that block the internal MET, and here are the drugs that are being looked at for downstream signaling for inhibition. So last month there was a 3-day meeting in Santa Monica on targeted therapies where they were talking about hundreds of different drugs that are in development at various stages. Looking at new drugs for, obviously, lung cancer. This is just FISH analysis showing you MET amplification. And this shows you a pre-treatment MET, pre-treatment PET-CT in this patient who had MET amplification. And here it is 25 days later, a tremendous shrinkage with crizotinib. So again, you wouldn't have known to treat this individual if you hadn't done the molecular testing. And here are all the MET drugs, or a few of the MET drugs that are in development. These two are in phase 3 already. So it is likely to change. So we go back to our pathway and we look at all these drugs that are in development that are trying to inhibit various other sources. They will work if you have a driver mutation, but if you have a mutation that is not the driver mutation of the cancer, they aren't going to work, or you may have to come up with a combination that looks at different pathway inhibition. So the last few slides, I want to direct you to this website. I have no commercial interest in this. This comes out of Vanderbilt, but it's an excellent website. You go to that mycancergenome.org. You select your disease. So it can be melanoma, it can be colon cancer, it can be lung cancer, it can be thyroid cancer. Then you select the gene and select the mutation, and it will tell you what the literature says. So here you've selected lung cancer, you go down and you say, okay, I want to see the HER2 exon 20 insertion, and again, that will give you the references of where to go to and tell you the frequency of the mutation. Response to erlotinib and gefitinib is uncertain, but if there is good data, it will tell you that. So it's hard to keep all of these mutations in mind, but here's our ALK mutation that will help direct you. Here are just about 6 different mutations in EGFR. And even though I work with this all the time, I can't keep all of these straight. I know the 2 major sensitizing mutations, they're here, but I sometimes forget about this mutation in exon 21. It actually is a sensitizing mutation. In contrast, this mutation predicts resistance. This mutation predicts resistance. So this is a website that you can use to help determine what your mutation is. And I guarantee you that if I have a thoracotomy and I wake up and they've got my lung cancer out, the first thing I'm going to be doing is saying, okay, did you send that for the mutational testing? I want to know, you know, Jim wants to know. So here is lung cancer. We used to think of it all as one big pie, but now it's being sliced and diced based on the mutations. And here is our new paradigm for treatment. In the past, you guys would aspirate 6 malignant cells, and it would be called non-small cell lung cancer, and we'd treat them all with the same chemotherapy. So this was when they got treated with Iressa, and 10% would respond. And we would say, wow, wasn't that wonderful? Why did that one person respond and those other 90 didn't? And the reason was, that's the one that had the mutation. So nowadays, we do genomic analysis. If we got the EGFR mutation, they get treated and they get a 70% to 70% response rate with the tyrosine kinase inhibitor. If they've got the ALK mutation, they'll get a 60% response rate. MET, as I said, is coming on. We don't have a drug yet approved for MET, but a couple of them are looking very promising. So this is the way the whole field is going in oncology, not just lung cancer, but pretty much every tumor that's out there.
I apologize, but this question is actually for Dr. McLeod.
Sure.
Yeah.
Or actually for both of you, I suppose. How do the RECIST criteria tell us to deal with a patient who has one lesion that's responding and another lesion that's not responding or getting worse? How do you describe that in your report, for example?
Okay,
in your
well, you
radioligand?
give them, you know, you're supposed to measure 2 per organ, and then you do a summation.
So you do a
Yeah,
summation,
so
average
if
of all
one, you know,
lesions.
obviously you
Okay.
just summate what, and give the mean for the 2 of them. Okay?
Okay.
Yeah, it usually means you're in trouble. Then,
Exactly.
yeah.
Variable response, right.
So you better get ready to change your chemo is what that means.
I got a question for Jim.
Yeah.
Jim, apart from having the pleasure of your company last night, you've woken up, you've got your pathologist who's taken out your theoretically cured limited stage disease, and you get your profile back. Would you take the drugs, knowing that you've got a significant chance of dying of your so-called cured disease?
So it depends on what stage I had. Basically, if I had a 1A, right now there's no hard evidence that adjuvant treatment is going to help, although there's a study that's going on looking at giving adjuvant treatment if you got the mutation versus placebo. So I wouldn't in that situation, but I would have that information available. If I had a 3A, you know, that maybe they resected but questionable margins, that sort of thing, I'd give some serious thought to taking it. It's not the standard of care at this point in time, but I think if you have any residual disease left, or like a phone call I got the other day, a patient had been treated with chemoradiotherapy for a 3B cancer, and then they needled a node after treatment, and it was positive, and he had the mutation for sure. You know, even though he hadn't clearly progressed, he wasn't a complete response to his initial treatment, and I would put that individual on the tyrosine kinase inhibitor.
I guess I'm looking at it from the point of view, we know people who are theoretically surgically cured relapse.
Right.
Despite our best efforts and clear margins and everything. Do you think there's a future role there for bioprofiling those people and giving them, if you like, the equivalent of the HER2/neu, the Herceptin, the maintenance therapy on a basis of reducing their risk of relapse?
I think that's the way the studies are going to go, and that we may be there in the future. We're not there quite yet. And again, the drug, you know, Tarceva costs about $4,000 a month, so it's not inexpensive. And you do develop resistance to it, you know, on the average of about a year later. So under those circumstances right now, I guess for an early stage disease, I would sit tight, see if I was going to be in that 70% that didn't have recurrence as opposed to the 30% who did have recurrence.
Thanks.